Hello and welcome to part 2 of our pulmonary discussion. In this section we're going to talk about pulmonary disease. So what specifically is happening with the pathophysiology and what that means to your patient. Some of the major classifications of diseases that are caused by a pulmonary problem include hypercapnia. So hypercapnia is a very high carbon dioxide level, so we have a high CO2 level. This is caused by a problem with ventilation, whereas hypoxemia is a condition that occurs because the patient's not getting enough oxygen into the tissue. So separate problems here. We have a problem with oxygenation versus a problem with our CO2. Now, these are also caused by different etiology. Hypercapnia, a problem with a high CO2, is caused by a lack of ventilation, whereas opposed to hypoxia is caused by the patient having poor perfusion. So you see there's a difference here. There's a difference between hypercapnia, that's ventilation, and hypoxia, that's going to be a perfusion problem. Just to differentiate here, when we talk about hypoxia and hypoxemia, hypoxia means without oxygen. It doesn't say where it is. It could be without oxygen in the alveoli. It could be without oxygen at the tissue level. Hypoxemia means a lack of oxygen in the blood. So what happens with many of our patients that causes either hypercapnia or hypoxemia is acute respiratory failure. Now, acute respiratory failure is simply a clinical observation. The patient stopped breathing. Look at what the words say, acute respiratory failure. That means we have failure to have respiration. In other words, the patient stopped breathing. Why? That's the thing you want to be able to ask yourself is why did this occur so that we can find out what's going on with that patient and treat it appropriately. Pulmonary edema is another common condition, and this is going to be caused by having excessive fluid in the lungs. So one of the situations that was talked about here on the first slide was this ventilation perfusion mismatch, and that's what this diagram is illustrating. So let's start up in the very top left corner where it says normal VQ. Remember, VQ is an abbreviation for ventilation and Q is for perfusion. I don't know why it's not VP, but we use Q as an abbreviation for perfusion. So when you take a look at the upper left hand corner, we have normal ventilation, air is moving in and out of the airway and into the alveolus, and we have a normal perfusion. You see the perfusion around the alveoli in the vasculature. Move over to the right and you see we have a low VQ, ventilation to perfusion ratio. Now, you see what's happened is we have impaired ventilation. Our perfusion remains the same. There's nothing wrong with the vasculature. The problem in this case is impaired ventilation. We have a narrowed airway. So maybe that patient's got secretions in the airway. Maybe this patient has got asthma. But we have a narrowed airway, which is limiting the amount of oxygen that's getting down to the tissues, and that's going to lead to a low ventilation perfusion ratio and to lead to hypoxemia. Okay, now notice over on the left lower, we have completely blocked ventilation and a collapsed alveolus. Now we have a very low ventilation perfusion ratio, and again, hypoxemia will be even more pronounced. Over in the bottom right-hand corner, now we have a decrease in perfusion. So we have impaired perfusion. This could be caused by a pulmonary embolus, for example, that's decreasing the amount of circulation getting to the alveolus, and the end result will still be the same, even though ventilation is okay. So air is moving in and out of the lungs. You see there's no problem in the airways, no problem in the alveolus, but there's not as much perfusion around that right alveolus, which then is going to lead to hypoxemia as well. So all of these conditions where there's altered ventilation perfusion lead to hypoxemia forming. Another of the conditions that was mentioned in our previous slide was pulmonary edema. Pulmonary edema occurs when we have edema, fluid accumulating in the pulmonary system. So we have an excess of water in the lung. It's an imbalance between our capillary hydrostatic pressure. So this could be caused by having a heart problem where there's too much pressure in the pulmonary vasculature pushing fluid out into the pulmonary system. It could also be caused by capillary oncotic pressure. Capillary oncotic pressure is the difference between the amount of pull we have from the tissues and the amount of pull we have from in the vasculature. This is related to solutes versus fluid in the blood. So if we have more solutes outside the vasculature, it's going to pull fluid out of the vasculature and into the tissues. Next would be capillary permeability. Capillary permeability can cause pulmonary edema as well. This happens in conditions such as sepsis. A loss of surfactant is also going to lead to pulmonary edema and lead to collapse of alveoli, leading to atelectasis. Most common cause are going to be heart disease, ARDS, toxic injuries. So a lot of different things here that could possibly cause patients to develop pulmonary edema. What we always want to be looking for in pulmonary edema is asking the question, is this fluid that has leaked out, so is this serous fluid, or is what we're hearing when we see this, is this just secretions that are building up in the alveoli? So we'll talk a little bit about how to differentiate those when we talk about the specific problems. What kind of symptoms you're going to see in this patient would include dyspnea, hypoxia, and increased work of breathing. So this is a graphic illustration of what we just talked about there with the different functions that can cause a patient to develop pulmonary edema. So starting over on the left-hand side over there, we have valvular dysfunction, some kind of heart problem is occurring. That's going to cause increased left atrial pressure, and that's going to cause too much pressure in the pulmonary capillary bed, increasing our hydrostatic pressure and pushing fluid out of the pulmonary capillaries and into the lung tissue. We can also have an injury to the capillary endothelium, that's in the middle, where we have increased capillary permeability. Now, again, there's a couple times that this frequently happens in the lung. That's with ARDS and with sepsis. So we have a movement of fluid and plasma proteins from the capillary out into the interstitial space, and that will fill the alveolus, and we have pulmonary edema. Lastly, over on the right-hand side, we can have blockage of our lymphatics, which is going to decrease the ability of the lung to be able to remove excess fluid from the interstitial space, and that will also build up fluid and cause pulmonary edema. Pulmonary disease or injury can cause the patient to develop a number of different complications, such as aspiration. Now, aspiration could be the original thing that's causing the pulmonary injury as well, but aspiration can be secondary to pulmonary injury on the other hand as well. The right lung is more susceptible. Remember when we looked at the anatomy and physiology, we said, hey, that right bronchus is straighter and shorter than the left one, and that leaves the right lung more susceptible to aspiration, because if the patient vomits and aspirates particles into the lung, well, the shorter, straighter bronchi is more likely to get the aspirate. Atelectasis is caused by alveoli that are collapsing. Alveoli can collapse just because they're not being used very much. Like, for example, a patient in the hospital who's not getting up and walking and things like that, that patient can develop atelectasis. Bronchiectasis is an abnormal dilation of the bronchi that can be caused by a variety of different pulmonary conditions. Atelectasis is a rather common situation that we see in patients in the hospital, and it's collapse of certain parts of the lung tissue. So there can be two different types of atelectasis that's caused in your patient. It could be compression, which means there's some kind of external pressure on the lung that's causing this to occur. So let's say the patient has a pneumothorax. The pneumothorax air is pressing in on that area of the lung, compressing the lung tissue, and then causing the alveoli to collapse. The second kind, which is the kind that we see far more often, is going to be the absorption kind. And this happens when we have the removal of air from obstructed or hypoventilated alveoli. And, basically just somebody who's not getting up out of bed, and just maybe after surgery and things like that, the patient's laying in bed and they're not taking deep breaths. So what happens is that the alveoli collapse because they're not being expanded, and the patient develops atelectasis. Some other pulmonary conditions that are of note include bronchiectasis. We talked about that before. occurs with other diseases, and it's caused, or the problem that occurs is we have problems with our bronchi. We can also have bronchiolitis, which is an obstruction, or I'm sorry, an inflammation, and possibly obstruction of small airways, kind of like a chronic bronchitis issue that occurs. One particular type is called BOOP, which is a B obliterans bronchiolitis. Late-stage fibrotic disease can have this occur, and what happens is we have a lot of fibrotic damage occurring to the lung. So the most often time that I have seen this in my experience, both BOOP and with bronchiolitis, is going to be in patients who have long-term chronic fibrotic disease of the lungs, so patients with cystic fibrosis and things like that. Abscess formation can occur with pulmonary disease, and can pulmonary fibrosis. If you recall from our anatomy and physiology, the pleura is on the outside of the lung, and there's a little space between the pleura and the chest wall called the pleural space that is filled with just a little bit of fluid, and that fluid keeps the lung from rubbing up against the chest wall. However, we can have some problems occur in that pleural space. So we can have more fluid accumulate in there than should be in there, so maybe some edema has formed in that area. That's called a pleural effusion. If that pleural effusion becomes infected, we call it an empyema. So in an empyema, we have infected pleural effusion fluid. We can have a pneumothorax, which is the presence of air in the pleural space. We can have a hemothorax, which is the presence of blood in the pleural space. We can have an open pneumothorax, which means there's a hole to the outside of the body. And we can have a tension pneumothorax, where air is starting to build up in the chest wall, compressing the lung, the heart, and maybe even the lung on the opposite side. In addition, we can have problems with the pleura, including chest wall restrictions, where we have deformity, and maybe, for example, something like a flail chest that's causing a restriction of our ability to be able to have respiration. Some additional definitions of pneumothorax are included here, including our open pneumothorax, which again means that we have a hole through the chest wall, so air is coming in from the outside. A tension pneumothorax, which means we have air building up, pressure building up inside the thorax. Now, one we didn't talk about yet is called a spontaneous pneumothorax. In a spontaneous pneumothorax, as the name implies, it happens spontaneously, which means that the patient may be just relaxing on the couch, watching TV, and boom, the patient develops pneumothorax. Okay, this happens because there's a little bleb, or an outpouching on the outside of the lung that bursts. It's like a little bubble on the outside of the lung that bursts and causes air to leak into the pleural space. So that's a spontaneous pneumothorax. Spontaneous pneumothoraces will often reoccur, so we do have to be careful about them. For that reason is that they will often reoccur in our patient. For example, one patient we had came in, she was an 18-year-old patient, and she was just watching TV with her boyfriend and suddenly developed chest pain and shortness of breath. She went into the emergency department. They found out she had a spontaneous pneumothorax, and they had to put a chest tube in. A chest tube goes into the pleural space and then allows us to connect up a suction device that'll pull that air out of the pleural space. But she was just sitting there watching TV, not doing anything. She didn't have any trauma, and it just spontaneously burst. This diagram is illustrating a couple different types of pneumothoraces. If we start at looking at the lung that's pictured on the right side of your screen, and you notice the little arrow of air coming out of the lung. So air is coming out of the lung going into the pleural space. That would be a simple pneumothorax. However, look at the arrow up toward the top and through the chest wall. If we have air entering from outside the patient's body, that would be considered an open pneumothorax, where air is entering from outside of the body. So when you're hearing definitions like open pneumothorax, open fracture, we need to be thinking about an opening to the outside of the body. Well, we need to get this air out of that patient's pleural space. And the way they do it is they instill a chest tube. So the surgeon will come in and put a chest tube into the patient. The chest tube goes between the ribs and into the pleural space. So it's actually rather invasive. We're going down into the pleural space here with this big tube. And that tube is then connected to a suction device so that air will leave the pleural space and re-expand the lung. As a result of trauma, a patient can develop what's called a flail chest. With a flail chest, we have multiple rib fractures occurring. So we have 2 or more ribs that are fractured in 2 or more places. This leads to having an area of the chest wall that is no longer connected to the ribs around it. In other words, a flail segment of the chest. This free-floating section of the ribs and of the chest wall will move paradoxically with the patient's breaths. So as the patient breathes in, it sucks in. As the patient breathes out, it pushes out. So this diagram illustrates in A and B what our normal respiration would look like. So the chest wall expands and it sucks air into the lungs, that's A. In B, the chest wall is becoming smaller, the diaphragm is going back up into its more relaxed position, okay, more of a curved relaxed position, and pushing air out of the lungs. Now look what happens in C. Here we have a flail segment, so there's a segment of ribs that are no longer connected on the right-hand side of the picture. So there's a segment of ribs that are no longer connected. Now when the patient inhales, it not only sucks air in from outside, but it's sucking air from the bad lung over to the good lung. And as the patient exhales, it pushes air not only out, but also back to the bad lung and pushes that part of the chest wall out. So what we're going to do with this to try to be able to deal with it is we're just going to put some tape over that loose segment of the chest wall to keep the chest wall from moving paradoxically so that the patient can oxygenate better. Along the same lines there, if the chest wall is restricted in any way, that can also lead to the patient having problems moving air in and out, which could lead to hypoxemia and hypercapnia. Some of the causes for a patient having chest wall restriction include trauma to the ribs, to the muscles, a skeletal deformity. You know, when you have patients who have that barrel chest from COPD, they have a skeletal deformity of their chest wall, and that can lead to having some chest wall restrictions. Obesity and neuromuscular diseases, compromised chest wall, maybe the patient's got a flail chest or some other condition going on. So what will happen with any kind of chest wall restriction is we'll get ventilatory impairment, which will increase the work of breathing, impair our gas exchange, cause dyspnea, hypoventilation, secretions will start to form because we're getting irritation, inflammation in the lung, and then hypoxia will then start to present. Bronchiolitis is a condition where we have inflammation of the small airways. Very common in children, could be caused by having a viral infection in children. It can occur in adults, usually in adults who have chronic bronchitis, which is part of our whole COPD mechanism. It usually associated with viral infections, but can also be associated with inhalation of toxic gases. In late-stage fibrotic diseases, such as cystic fibrosis, we can see bronchiolitis obliterans, and I mentioned that earlier. This can also happen in late stages of bronchiolitis. Another couple conditions that I mentioned briefly earlier was abscess formation and cavitation that can occur in pulmonary disease. An abscess is going to be a well-encapsulated area that we have fluid that has accumulated. Now typically we don't call it an abscess until that fluid becomes disturbed in some way. Maybe it has a lot of white blood cells in it, maybe it contains bacteria and bacterial toxins, so it may be infected. We can have a consolidation. Consolidation means we have an area of the lung that has become kind of solid. Usually this is the result of having an inflammatory response and then the fluid building up in the lung, such as fluid that looks like pus, basically. We can have cavitations occurring. This occurs in certain types of cancers where we actually have destruction of the lung tissue, it becomes necrotic, and we have like a hole dug out of the lung where that necrotic area has formed. Pulmonary fibrosis occurs in people who have situations where they would have an increased amount of connective tissue, in other words, fibrous tissue, that's occurring in the lung. And one of the common times, or one of the commonly times that people are probably familiar with is cystic fibrosis. And as was mentioned earlier, chest wall restrictions and flail chest can also lead the patient to developing problems with their pulmonary disease. Pulmonary disease can be associated with or even caused by having inhalation disorders. So we have an exposure to toxic gases. Remember, these gases are going in the lungs, so we got to breathe. So our body's telling us breathe, breathe, breathe. And as you breathe in, you're breathing in these toxic gases, and they can be causing damage to the lung. Now, these things that we're talking about here are things that happen over a long period of time. So when we're talking about developing some irritation, inflammation, and damage to the lung as a result of inhaling silica or asbestos or coal. We're talking about conditions that occur over a long period of time and eventually end up looking like COPD. We can also have an allergic alveolitis where the patient has an allergy, a hypersensitivity, that causes the alveoli to become inflamed as well. So let's talk a little bit about specific pulmonary disorders and what they're going to look like in your patient. So one that's very common that we see often in patients in the hospital is called ARDS, which is Acute Respiratory Distress Syndrome. Maybe you've already heard of this from some previous experience that you've had. What happens in ARDS is we have an overwhelming, out-of-control inflammatory response of the lung. We have malignant inflammation of the lung. We have malignant inflammation of the lung. Now, three main things happen with inflammation. We get vasodilation, capillary permeability, and clotting. Think about that stuff happening in the lung. Vasodilation, well, that might be a good thing. We get more perfusion of the lung. But capillary permeability, oh, that's not going to be good. Remember, capillary permeability can cause edema formation. And when we get edema that's caused by capillary permeability, that edema can be thick and can include things like proteins and cells and all that kind of stuff. So that could be a real bad situation. All right, that's not good. And then the third part was clotting, remember? So we get clotting occurring. Clotting is going to cause millions of tiny little pulmonary emboli in the lung. Coupled up with that edema that's forming, we're going to get a lot of lung destruction occurring here as a result of having ARDS. So symptom-wise, we could anticipate the patient's going to develop initially hyperventilation with respiratory alkalosis. Now that's an initial early sign. The patient's breathing faster. At this point in time, we don't have the edema formation. You don't have a lot of symptoms, so it doesn't make a lot of sense. You're looking at this thinking, I wonder what's going on with this patient, that the patient is breathing so fast and having the respiratory alkalosis. And we can also have dyspnea and hypoxemia occurring as the disease progresses, and as the alveoli become more affected, we're not going to be able to get oxygen across that alveolar capillary membrane, and the patient will develop hypoxemia. The body's response to hypoxemia is to cause the patient to breathe faster. Therefore, we get dyspnea. Eventually, we'll develop a metabolic acidosis. This is related to some of the changes that are occurring out in the tissue as a result of hypoxemia. Initially, though, we'll get a respiratory acidosis that's caused by the direct lung injury itself. Further hypoxemia, more hypotension, decreased cardiac output, and death can result from ARDS. So how on earth are we going to know that this patient could have ARDS? Well, we'll look at the physical examination. Remember, we're looking for somebody who's going to be developing that capillary permeability and clotting in the lung, and we're going to be looking for the risk factors that could cause ARDS. Anything that causes systemic inflammation, such as sepsis or any other kind of trauma or infection that's occurring in the body that could be causing an overwhelming inflammation in the lung. So we look for a physical examination. We can check our blood gases to look for either that early sign, which is respiratory alkalosis, or the later sign, which is respiratory acidosis, followed by metabolic acidosis. And then we're going to give the patient supportive therapy. There's no real treatment for ARDS. We just have to support the patient long enough until the body recovers on its own. So this slide here is showing some of the different mechanisms that are occurring in ARDS. We have that indirect or direct lung injury going down the left side is causing the injury to the alveolus and damaging some of the cells, decreasing surfactant. Atelectasis starts to form, and then we're going to end up with respiratory failure. Over in the middle, we have capillary endothelial injury, which causes capillary permeability and more fluid forming in the lung. Because of, first of all, a release of inflammatory cytokines, we get vasoconstriction in the lung, which will further worsen the hypoxemia we have. Now, the lung's response to hypoxemia is to cause vasoconstriction as well. So all this vasoconstriction is really going to cause problems for the patient's oxygenation. Way over on the far right side, it talks about releasing our growth factors, and this is what's going to cause a chronic pulmonary insufficiency, at least the possibility of which, in a patient with acute lung injury or ARDS. In our surgical patients, we can have a postoperative respiratory failure, and this occurs as a result of atelectasis, pneumonia, possibly pulmonary edema or pulmonary emboli. Atelectasis can occur because during surgery, the patient is not taking deep breaths. If they're on a ventilator, the ventilator doesn't give them deep breaths, it just helps them to ventilate normally. So this is why it's so important after the patient's had surgery to have them do the deep breathing. Pneumonia can occur too as a result of not having the deep breaths and secretion starting to form in the lungs. So again, we want to have that deep breathing. We want to do some frequent turning and early ambulation so that we're moving the patient around. That's going to help to mobilize secretions. Pulmonary edema could form, so we want to be careful if the patient has heart failure or any kind of cardiac condition. And pulmonary emboli. So this is why, again, it's important to get the patient up and ambulating, get them moving so that we're able to prevent those blood clots from forming in the legs. So our prevention strategies. Now these things that are listed here are called pulmonary hygiene. So you may see this in other documents that you get somewhere along your nursing career and listed as being pulmonary hygiene. Frequent turning, deep breathing, early ambulation, air humidification, and incentive spirometry. So as you may have imagined by looking at the previous slide, asthma has this allergic basis to it. Yeah, it's an inflammatory condition that occurs in the airways, but it's caused by an underlying allergy that's occurring in the patient. So this underlying allergy is what's stimulating the patient to develop this hyperactivity of the airways. Now, the patient doesn't have to come in contact with an allergen to have an asthma attack. This patient may be just inhaling, a perfume or something like that and have an asthma attack. Okay, it doesn't mean they're allergic to perfume. It just means that that particular thing, now when they're inhaling it, happened to cause irritation to already irritated bronchi and cause them to have an asthma attack. In asthma, we get wheezing, dyspnea, and tachypnea. So wheezing usually starts on expiration first. Remember, the chest wall, including the airways, are smaller during expiration and bigger during inspiration. How we can try to assess the patient who has asthma is using a peak flow meter. This will help us to be able to determine how much air the patient is able to move in and out. We can give the patient oral corticosteroids and inhaled beta agonists and anti-inflammatories in order to try to control their asthma. So again, a lot of stuff going on here. When a patient has an asthma attack, you can see all the different immune mediators and allergic mediators that are going to town here in the early asthmatic response. There can also be what's called a late asthmatic response as well. So the person comes in contact with the allergen and then 8 hours later, 24 hours later, has an asthmatic response. So that's not necessarily always going to happen right at the time, but it could happen much later with this late asthmatic response as well. Don't get real involved in looking at all the details of this. Just understand that there is both an allergic and an inflammatory process that's going on here in asthma, and we can have both an early and or a late response in our patient. Now, I want to be clear about differentiating COPD, chronic obstructive pulmonary disease, from asthma. COPD is a different condition. This is a chronic inflammatory condition caused by inhaling irritants over a long period of time. In chronic bronchitis, the patient has chronic mucus production, and this is defined as having a chronic productive cough that lasts for at least 3 months of the year, and for at least 2 consecutive years. So you get pneumonia 1 year or bronchitis 1 year, and you're coughing for 3 months. That does not mean you have chronic bronchitis. Now, if that happens 2 years in a row, then they might start to analyze, they might start to do some studies to try and find out if you have chronic bronchitis. But that's the underlying definition here of what it takes in order to be able to say, hey, this person's got chronic bronchitis. What happens is that we have inhaled irritants, for example, cigarette smoke, that increases mucus production and the size of the number of mucus glands producing more mucus in the lung. The mucus is thicker than normal, which causes problems in getting it back out of the lung. So we're going to have to probably use bronchodilators. Expectorants. Expectorants are medications that draw fluid into that mucus to make it thinner, so hopefully it'll mobilize better. And chest physical therapy may be used to treat. Chest physical therapy is using vibration and percussion in order to break up those secretions so they will mobilize upward. This is an interesting picture of what happens when air is moving past secretions that happen to be forming in those small alveolar ducts. So you see here we have just a little mucus plug occurring here, and we have air moving in and out of the one on the left. Not great. But then during expiration, you see, because again, during inspiration, the airways get bigger. During expiration, the airways get smaller. So they get smaller with the picture on the right. And then that mucus plug there is starting to block the airway, and the air is getting trapped in the alveolus. Now, this is what happens in patients with COPD that causes them to have these big, hyperexpanded lungs. COPD contains another possible diagnosis, including emphysema. So COPD is kind of our general heading, chronic obstructive pulmonary disease, for problems, chronic problems that are occurring to the lung as a result of having chronic inflammation and irritation of the lung. So one of those would be chronic bronchitis, where we have too much mucus production. The second one would be emphysema, where we have the permanent damage occurring to the lung. Permanent damage occurring to the lung as a result of this chronic inflammation. So these are just a couple slides here showing you alveoli. We have the nice little round alveoli, then we have the really big distended ones there that are occurring in patients who have emphysema. So to help differentiate here a little bit more, we have this diagram where the patient is, let's say, smoking, for example, or maybe there's air pollution in the air, and that's causing inflammation of the airways. This then starts to cause a couple different problems occurring in the lung. Continuous bronchial irritation and inflammation, which causes bronchitis, chronic bronchitis, and increased protease activity, which starts to cause the destruction of elastin. Elastin is part of our connective tissue in the lung, which then leads to destruction of lung tissue. We get the overinflation of the lungs, and that's emphysema. Both of these things together or separately, the patient may only be diagnosed with emphysema, but may also have mucus production. The patient may be diagnosed with chronic bronchitis, but also have lung destruction. So these things go hand in hand, and together they cause airway obstruction and air trapping, loss of surface area in the lung for gas exchange, which means that we're going to have hypoxemia and hypercapnia. We can also develop a cough, dyspnea, and Cor Pulmonale, which is another name for right-sided heart failure. Pneumonia is a condition that occurs when we have an infection of the lung. Here are some common different types of pneumonia that we can see in patients, but one of the things that often occurs is that we have a community-acquired pneumonia. Somebody comes into the hospital and they say, hey, I've got pneumonia. They're admitted from the emergency department with pneumonia. That's community-acquired pneumonia. They got it out there in the community. They got it at home. Now, somebody else can also be in the hospital. They had surgery and now they developed pneumonia. That's a hospital-acquired pneumonia. We want to be careful with those because a hospital-acquired pneumonia is something we gave to them. So we want to be sure that we are doing good hand washing and so on so that our patients are not developing pneumonia in the hospital. We talked in another section about necrosis, and maybe you recall from that section, that caseous necrosis is one of the conditions that can happen with tuberculosis. So tuberculosis is a bacterial infection of the lung, and it's going to be airborne transmission, and hopefully we're trying to control this in our communities and in the United States. We're trying to keep this down. However, there has been a little bit of a recurrence of TB that has been kind of floating around, and that's probably because people have not been getting tested and we're not treating it appropriately to keep it out of the population. So take a few moments here and look at all the signs and symptoms you may see with tuberculosis, but we get that progressive fatigue, the malaise, the anorexia, weight loss. The main thing is just this chronic productive cough. So chronic cough, 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 oftentimes with some blood in the cough, maybe a low-grade temperature, maybe some chest pain, but that's basically what we see is that cough, cough, cough. And then the patient comes in to have the chest x-ray. We say, oh, wow, look, there's TB on the chest x-ray. Unfortunately, the treatment for tuberculosis is not fun. It lasts from 6 to 12 months. This is a difficult infection to get rid of. So the patient's going to be on antibiotics, and oftentimes these antibiotics are kind of difficult on the liver, for example, and can lead to other kinds of social restrictions on the patient while the patient's taking the antibiotic. Well, acute bronchitis can happen too. In acute bronchitis, the patient has an infection or inflammation of the airways or bronchi. So in the wintertime and cold climates, well, you see a lot of bronchitis because the patient is inhaling, or maybe the patient had a viral illness and they had an upper respiratory tract infection, and now this has just kind of settled on down into the bronchi. You know, you sleep at night, and when you're sleeping, oftentimes drainage from the sinuses will go down. It gets down in the trachea, goes down in the bronchi, and can set up shop there as an infection. So acute bronchitis, you're going to see similar kind of symptoms that we see with pneumonia, where the patient's going to have maybe some chest pain, coughing, especially with a productive cough, maybe a little bit of a low grade or maybe a little bit of a fever with this, and that's the kind of symptoms we typically see. So usually it's going to be treated with an antibiotic. So this may describe it a little bit better for you here. We have one of those conditions occurring, venous stasis, vassal injury, or we have hypercoagulability, which is causing a thrombus to form. The thrombus dislodges, it breaks free, goes back through the central circulation back to the pulmonary circulation and causes occlusion. This leads to all of the symptoms that we see associated with a pulmonary embolism. So you might want to pause the video here for a moment so you can take a look at the symptoms that are caused by our PE. And in more of a goofy way, this shows the symptoms that are caused by a PE. So we have a patient here and have the risk factors listed down there at the bottom: immobility, obesity, deep vein thrombosis is DVT, postoperative patients. So a lot of our different types of things are listed there. Now over on the right hand side at the sill in that same box, it talks about our venous stasis, our endothelial injury, and alterations in coagulation. So then you see we have that clot going back up through the venous pathway, getting stuck in the lung. Some of the treatments we may use would be thrombolytic therapy. Some of the symptoms we may see include tachypnea, hypoxemia, dyspnea, tachycardia, maybe even hemoptysis, where we have blood in the sputum. And in our blood gases, anticipate seeing a low CO2, at least initially, a low PO2, and an increase in our pH. So we have a respiratory alkalosis associated with hypoxemia. Pulmonary hypertension can be classified as either being arterial or venous, depending upon which side of the pulmonary vasculature is involved. Now remember, when we're talking about the pulmonary system, we're talking about the arterial end being the unoxygenated blood coming to the lung versus the venous end being the oxygenated blood coming to the heart. So on the arterial system, that might be caused by pulmonary hypertension from a respiratory disease. Pulmonary hypertension caused by thrombotic and embolic disease is also arterial, whereas if it's a disease caused by a patient having a cardiac condition, that would be pulmonary venous hypertension. Now in this slide it's showing the process by which somebody with COPD can end up developing pulmonary artery vasoconstriction, which leads to increased pulmonary artery pressure, which causes the patient to develop chronic pulmonary hypertension. And that chronic pulmonary hypertension then causes the person to develop right heart failure. Now, I mentioned this earlier, but Cor Pulmonale is another name for right heart failure. So the patient has right heart failure. You're going to see this is an older term for right heart failure. You can see this maybe listed in some patients' charts where it says Cor Pulmonale. In general, now you're going to hear people talk about right heart failure, and you're probably going to see that listed in the patient's chart. So just know that those terms are kind of interchangeable. Now again, we're talking about the right side of the heart. We're not talking about the left side, we're talking about the right side of the heart. So the right side of the heart is going to back up into the systemic circulation. That's where we're going to see the problems with the right side of the heart, with Cor Pulmonale. So just keep that in mind when you're thinking about right-sided versus left-side. One of the most common symptoms we see with right-sided failure is going to be edema. And you see in the picture here, it's showing the dependent edema of the patient's feet and legs. In most cases, edema and signs of right-sided heart failure are not caused by independent heart failure right on the right side, but of left-sided failure that is backed up through the right side. So rather than it being independent right-sided failure, because the right side rarely fails by itself, instead it's probably bilateral failure. Well, in addition to those problems we talked about so far, we can also have a number of different cancers of the respiratory tract, starting all the way up from the top with lip cancer. Lip cancer, of course, is going to be very common in people who smoke. So any kind of smoking is going to increase the risk there. Along with laryngeal cancer, any kind of smoking is going to increase the risk. Smoking and drinking alcohol increases the risk of both of these types of cancer from forming. And this is showing a picture, a very dramatic picture of what a lip cancer would look like. A patient usually is going to end up going to the hospital sooner when the lesion is smaller than that, but that's obviously a very large lesion that has occurred on the patient's lip. Laryngeal cancer occurs when we have cancer occurring somewhere in the larynx, and this can cause a lot of problems. First of all, it can cause problems with the patient's ability to be able to breathe. But secondly, it can also cause problems with the patient's ability to be able to speak. And laryngeal cancer may require the use of surgery in order to be able to remove it. Well, guess what is the most common cause for lung cancer? You probably already guessed it, cigarette smoking, right? Heavy smokers have 20 times greater risk of developing lung cancers than non-smokers. And there's other risk factors in other parts of the country. Coal dust, for example, or heavy pollution, those are also risk factors for people to develop lung cancer as well. So if you've got somebody who lives in an area with high pollution and smoke, or a person who works in a coal mine and smokes, boy, they've got a lot of environmental risk factors here for lung cancer. And not uncommon to see people in their 40s and 50s dying of lung cancer because of all of that damage that's occurring to the lung. Lung cancer is going to be divided out into three main categories: non-small cell lung cancer, and this includes squamous cell carcinoma and adenocarcinomas, large cell carcinoma, which is an undifferentiated kind of cancer, and then a small cell carcinoma. So we have three major categories here, with the subdivision of the squamous cell carcinoma and adenocarcinomas under the small cell or non-small. As we previously discussed with cancer, the evaluation and treatment options for a patient who has cancer include the TNM classification system of tumor, node involvement, and metastasis. So we can look at that to determine how involved or how progressed this particular cancer is, and then decide upon the appropriate surgery or appropriate treatment, whether that's surgery, chemotherapy, radiation therapy, etc. An upper respiratory problem that includes the epiglottis is called acute epiglottitis. This is a bacterial infection that has caused the patient to have severe, rapidly progressive, life-threatening kind of a condition, because the epiglottis is up there in the upper airway, and as that becomes swollen and enlarged, it can block the patient's airway and the patient can have problems breathing. Symptoms include a high fever, sore throat, and inspiratory stridor. Now, a stridor is a different sound than a wheeze. A wheeze is a high-pitched musical sound on inspiration. A stridor is heard primarily on, I said that backwards. A wheeze is a high-pitched musical sound on expiration. A stridor is primarily heard on inspiration. It's a high-pitched sound. It sounds like a squeak on inspiration. It's caused by the upper airway. And this is a real emergent kind of a condition, because we could have blockage of the airway and then the patient couldn't breathe. So this diagram here is illustrating some of the different conditions that are occurring that are causing the patient to develop epiglottitis, and then the treatment and the symptoms that we see in our patients who have epiglottitis. Although this is usually associated with children, epiglottitis does also happen in adults. This interesting picture here is illustrating what kind of sounds we're going to hear in different parts of the airway. When it's way up there in the nasal pharynx, we're going to have snoring occurring. When we move down into the voice area, so down here into the larynx, now we're going to have an inspiratory stridor. So that's where we hear the inspiratory stridor. We get down a little bit further now into the trachea and the bronchi. Now we're going to hear an expiratory stridor, or maybe even wheezing. So our main concern here is that the patient's going to have this inflammation and edema occurring in the upper airway, causing upper airway obstruction, leading to increased resistance to airflow, leading to collapse of the upper airway and respiratory failure. So the symptoms, we hear this loud snoring, excessive daytime sleepiness. You see, because the person with sleep apnea doesn't really get a good sound sleep, even though it seems like it from all that snoring. It seems like, wow, they are really out of it here. But they're never really getting down into that deep sleep. What happens is that this airway obstruction that occurs is going to wake this person up hundreds of times an hour, so maybe even more frequently than once a minute the patient's going to wake up. And the patient never gets into that really deep sleep. Now, they're not waking up and, opening their eyes and everything else, but what's going to happen instead is that they're just kind of going through these upper levels of sleep and never getting a deep sleep. And that's what causes the excessive daytime sleepiness, because the patient doesn't get into the deep sleep. So treatment-wise, we're going to always start with the non-surgical stuff. Change the sleep position. Do all the mechanical stuff. Get the head of the bed up. Decrease their weight. So if we can get them to lose weight, we may use CPAP machines and things like that. We're not going to go into the surgical options until we've exhausted all the non-surgical treatments. Now, even though we have differentiated this out and separated this out into respiratory distress syndrome of the newborn, so this is the same condition we see in ARDS. The mechanism is different, but the destruction and the results are the same. This is also known as hyaline membrane disease because what happens is the patient does not have an adequate amount of surfactant being produced, and that's what's causing the inflammation and irritation in the lung that causes the respiratory distress syndrome. Another condition that I have mentioned previously when we talked about bronchiolitis was this cystic fibrosis. Okay, so it's an autosomal recessive multisystem disease, and what ends up happening is the patient will develop thickening. So they're going to develop thickening of the connective tissue in the lung, which causes fibrosis, and then they're also going to have a thickening of the mucus. So this abnormally thick mucus starts to become stuck in the airways and cause a lot of difficulty with the patient's breathing. The chronic inflammation is going to lead to hyperplasia of the goblet cells. So that's going to cause even more secretion formation and more difficulty with moving those secretions. So this diagram here is showing that we have this underlying defect that's occurring with cystic fibrosis, causing the dehydrated mucus, impaired mucus clearance, etc., and leading all the way down to the patient developing bronchiectasis as a result of all of the problems occurring with the mucus and with our inflammation and connective tissue damage. Over on the right-hand side is showing some of the symptoms involved with cystic fibrosis, our chronic cough, recurrent upper respiratory infections, that thick, sticky mucus, and chronic hypoxemia. Then over on the left-hand side, some of our treatments. Unfortunately, a lot of the treatments that are used are medications that are going to decrease the immune response to try and decrease inflammation. And that's going to cause the person to have the risk of having more infections and more problems. Well, I want to thank you for joining me for part 2, which is pulmonary disease. This is David Woodruff, and until next time, bye now.